Everybody, my name is Lakshay Chalna. I'm an emergency physician who's practicing in India, and via this talk, I would be sharing some of my thoughts on working as an emergency physician in India. I'm doing this talk as a follow-up of Nicolas Pineda's talk, which was released last year in October 2014. Now, Nicolas is a great guy. I got an opportunity to meet him during the teaching course in 2014 October, which was held in Baltimore. Nicolas, my sincere apologies for reverting back after such a long time, and I really appreciate all your patience and the work which you have done. Now, at the outset, before we actually jump into the talk, I would like to state very clearly that these are just my own thoughts and opinions. I'm not someone who is practicing emergency medicine for decades. This is just based on my 4 years of endeavors in EM. So please, please, please don't get upset if you don't agree with bits of this talk. I would be more than happy if you could add on or if you could share your views on this and give your insight. Nicolas did mention his thoughts, and I agree with most of them. This is just an addition of my perspective from a country where emergency medicine is still in the developing phases. This is where I work, and I belong to India, and I work in the city of Hyderabad. I work for about 45 hours every week, and if you look at the number of hours, I work for only for about 25% of the time. So I basically work in a 4-day cycle: morning shift, then evening shift, and followed by a night shift on day 3, and every 4th day I get an off. What this does is this gives me enough time for my family, for social media, for blogging, for podcasting. Let's move on. I have 10 key points here that I want to put across, and I would be going through each one of them very briefly, stating my thoughts and opinions. And I'll start with the issue of night shifts. Now, we all know people who hate doing night shifts, and as we climb up the ladder in emergency medicine, it eventually happens that we stop doing the nights, at least in India. But there are very few of us who like to continue working in the nights, and we have our own reasons for that. So I'm just going to look at the pros of doing night shifts. So when you do a night shift, you get to make the most critical decisions. That gives you a deep sense of responsibility, a deep sense of maturity as a final year resident or as a registrar or as a junior consultant. And with every night shift, a time comes in ER when you're not so busy, there are not so many patients around, and you get to know the people who are working with you. You get to know them so well. And then all of a sudden you're performing a resuscitation on someone. You're working towards a common goal, and all your conversations, all your resuscitation efforts, they somehow, somewhere connect you so well with your residents, with your colleagues, that you develop a bond with them, which I feel is just not possible in other specialties. You build a lifelong bond here, and these are the relationships which go a long way. After all, emergency medicine is all about relationships. It's whether it's between your patients, between your colleagues, between you and your nurses, your physician assistants. EM is just all about relationships. In addition, if you're doing nights, you also get enough time to spend with your family. This is my wife and my parents. I get enough time to spend with them because I work in a 4-day cycle, and I get 24 hours of break after every shift, in contrast to my surgical colleagues who work for 36 hours and then they come back for OPD shifts and then they go back for night shift again, unlike emergency physicians who go for frequent vacations and who go for frequent adventurous trips, and thus avoiding the burnout, which is our second point here. So I just mentioned about burnout. When I joined emergency medicine, there were days when I thought, I should leave this. Why did I join this program? We all feel like this at some point in time with every specialty. This is not only with emergency medicine, but with time I began to realize that the workload, the resuscitations, and taking care of critically ill patients isn't really the reason, isn't really the cause for this stress. Okay, it's because of the lack of appreciation and constant discouragement of some people, which was causing this burnout or this stress. Then on one fine day, I was lucky enough, I had a conversation with the ECG guru, Dr. Amal Matu, and this happened back in March 2013. His few words of appreciation for the first time after 2 years of my training in emergency medicine. It almost brought a tear in my eye, and since then I changed. I made it a policy. I'll be nice to people, and I learned how to appreciate people. So just be nice, say thank you, say well done, and you can make someone's day with this gives you a lot of positive energy to people around you, and you can really change the work dynamics with this. Don't suck out positive vibes from people. Don't be cynical, don't be negative, don't be nasty. It won't take you anywhere. And another possible reason for burnout could be not spending enough time with your loved ones. So always make sure you spend some time with them, your family, and have a work and life balance. Okay, learn to say no to some things, and always keep your professional and personal life separate. Don't take it out on your family, on your wife, or on your kids. If you have a bad day or a bad resuscitation, don't take it out on them. Let's talk about the specialty. Emergency medicine is a really broad specialty, and we take care of undifferentiated patients, and this is my favorite one. This is what I love about emergency medicine. We always have stories to tell. We see undifferentiated patients from a crushed hand to Cushing's to necrotizing fasciitis, tamponade, and with this what we need to do is we need to always work with an open mind to assess these patients. Because we don't know if there's something wrong with their heart, if they're coming with chest pain, or it's their esophagus, or it's their lungs. And we can't really say your echo is normal and the pain is not related to your heart. I'm not sure about the lungs. We don't say like that there's not a fracture there in your bones, and let's call the general surgery. This is not my case. We don't say like that. Again, I'm not offending any specialty with this. So we see patients from all classes of society. Sometimes we see a politician, and sometimes we see a poor man who has no money for his treatment, but we don't ask for bills before we intubate them, and we don't ask them to pay before we treat them. We just can't do that. And in addition, we also know something about every specialty, and this essentially is emergency medicine in my mind, knowing something about everything. The challenge that comes with this is we need to have extremely strong general emergency medicine knowledge background, and for that we need to read more and more. We need to keep up with literature, to get into in-depth discussions with attendings, consultants, and specialty registrars. We never look like fools. We can always participate in discussions because we know something about everything. And number 4 is we are still a rare species. There are not many emergency doctors as of now in India. The major advantage of being in India at this point of time is we are still rare. Unlike other developed nations where there are tons of emergency physicians like the United States or Australia, there is still a lot of work which needs to be done, and you can be the next leader in your country. You can be the next Scott, Waingart, or Tintinelli of your respective countries. For that, you need to focus, you need to work hard, you need to inspire people, talk to people, educate them, and take it to the next level by pushing them. So there are lots and lots of opportunities here, and you are already in the right place. You just need to make the right move at the right time. Also, you must need to work together. Be not involved in corruptism and criticize each other. What we need to do is we need to work together as a team, holding hands, helping each other, and promoting each other. Because alone we can be smart, but together we can be brilliant. Number 5 is EM is a very young specialty in India, and wherever and whenever I go for a conference, I see a majority of people who belong to 25 to 45 years age group. Unlike other branches in medicine, we are probably the youngest doctors, and we work for 24 hours, 24 into 7, 365, saving lives. What we need to do is we need to talk to each other, know each other well, hang out with each other, collaborate, make friends. We are a rare species. We need to stay connected and we need to stay together. It is extremely important to have like-minded individuals. It can be your colleagues, it can be your friends, people whom you meet at the conferences, and among them, among these like-minded individuals too, you need to find one good EM friend with whom you can share all your stuff, so you can vent out everything. Now, don't pile up issues. Don't be so hard on yourself. Have frequent meetings with them. Get together and find a partner with whom you can vent out stuff. It can be your best friend, your mentor, your spouse, and this is extremely important to do. Number 6 is having an open mind, and we cannot have tunnel vision. We should be always willing to learn, and somewhere, somehow we all get this feeling that I know everything, and trust me, I have been through this. I learned it the hard way. What this does is this will lead to conflicts and arguments. We cannot have tunnel vision. To avoid conflicts and arguments, we need to be willing to learn. We need to have an open mind. For example, let's take a hypothetical situation here, and if you get a patient with unstable paroxysmal supraventricular tachycardia, and you want to deliver a shock to this patient because you are AHA certified and you have been through the guidelines of AHA, but the cardiologist is right next to you. He wants to try some medications first, and he knows that patient is unstable. So what I recommend here is don't land up into an argument here because of this, and don't generalize anything about the cardiologist because of this. Let's face the reality. He's a cardiologist, and he's the person who is going to admit the patient. The patient is going to get admitted under his care, and he is from a specialty which brings a lot of revenue to the hospital. So if they want to give medications for an unstable SVT, that's okay. And if they want to shock a patient with a stable tachycardia, that's fine too. Now, both the things work for SVT, and most of the medicine is opinion based. Don't fight with them. Don't get into arguments because of this. Now, I'm not saying or be very timid and tolerate whatever they are saying. Don't argue and don't fight unless there's a real harm to the patient because of something what they are going to do. If you want to really change this, make them feel important first. Be ready to learn, show enthusiasm, and if you really want to change your thoughts, understand their reasons for this. Make them count on you first, and then get close to them, and then open with them. Imagine this is really hard for a 50-year-old consultant or attending who is practicing cardiology for last 20 years to give up his ego. So don't fight, don't really fight unless there's a real harm to the patient with what they are going to do. Remember, they have more experience and you don't know everything. Nobody does. Learn from the other consultants. Be nice to them. Try and understand their perspective. Have an open mind. Have discussions. Don't have arguments. Have discussions with them. We are a very dependent specialty, and we are a very vulnerable specialty too. It is finally nephrology or internal medicine or cardiology who is going to admit the patient. So if you want to cut down the confusion, if you really want to cut down the confusion, the best thing to do is, which in my mind is to have written departmental or written hospital protocols that would prevent everyday conflicts. Number 7 is educating people. This is extremely important, and you need to be a mentor for your residents. You need to guide your residents through their residency, help them by providing regular feedback, regular teaching sessions. You can also learn stuff from your residents, what you don't know. They all know something which you don't, right? So build a rapport with them, have a group of educators. It is your responsibility to teach them. Communication is number 8. This is by far the most important skill which we need to master, and this is not really taught in emergency medicine, unfortunately. Now, the communication can be either with your patients, with your nurses, with your colleagues, with your consultants, or it can be while giving a talk or when you're on social media. This is something at which we all should be experts. For example, regarding communication with the patient, septic patients don't really care if you achieved a MAP of more than 65. They need someone to talk to them. They need someone to explain them the process, what is happening. You can achieve all the EGDT goals. If you still believe on EGDT, you can achieve all the goals, but you can still have an extremely unsatisfied and angry patient. And on the other hand, you can have a patient who is septic and you missed a couple of EGDT goals, but you spoke to him, you have explained him the process, and you have anticipated what is going to happen in future, and he's very happy even though you missed a couple of EGDT goals. So take your pick which one you want. You want a happy patient with a missed EGT goal, or you want an extremely unhappy patient who got antibiotics within 1 hour and all the other goals of EGDT. So talk to your patients, explain them what is happening and what you are anticipating further. What we also need to do is we need to also learn how we need to behave and how we need to talk with consultants, how we need to present cases to them. We must learn this, and we must also know what they would like to listen to. We need to know and speak the language of every possible specialty if we want to excel. This is a crucial skill often not taught again to the residents. This often comes with time when we screw up and when we goof up, and we learn again from our mistakes over time. Diplomacy is something which all of us will eventually learn with time, and this is very vital skill for emergency physician. I'm not going to dwell on this as I'm also not an expert in this. I will just put it like this: an emergency physician must know the art of getting someone else to do something what he wants to get done. Hey, I'm still learning this skill, but this is extremely important. Coming to having a mentor, this is number 9. I consider myself very lucky, very fortunate, because I have already worked with some big names from emergency medicine so far. In fact, a bulk of this presentation, my thoughts and opinions are shaped up because of the people whom I've met over the last 4 years and I've worked with. So having a mentor is extremely important. You need to learn from someone who really wants to make you big. And these are some of my mentors. And having a mentor is extremely important. You can look up to them. You can choose one early in your career, okay? And you need to talk to them frequently. Take feedback from them about your performance, about how you're doing. And my mentors have taught a lot of stuff to me. It's about medicine or it's about life. I just can't thank them enough. So coming to the last point, FOMED. This is probably again one of the key points. This is something which most of us are not comfortable with or aren't using it as of now in India. Now understand, you need to be active on social media. You need to speak up, get involved in FOAM. FOAM is free open access medical education for those of you who don't know, and you can do this via Facebook, via Twitter. You need to speak to leaders. And with FOMED you can do that very easily. You can speak to the leaders directly, take part in discussions, comment on the blogs, share your thoughts, ideas. Just get involved in this, and you will realize apart from the clinical stuff, there's a lot more. There are a lot of opportunities here which you can do and you can achieve via FOAM. But medical education is changing, and it has already changed a lot over the last decade. I'm proud of the fact that emergency medicine and critical care, we are the leaders of free open access medical education, and now we are also pulling other specialties into FOAM. One word of advice from me regarding FOAM: I am a very enthusiastic FOAMed supporter, but for the residents I would like to add one point here, that please don't believe everything that you read on FOAM. Okay, please don't believe everything that you read on internet. Have discussions. Don't start practicing just because you read it somewhere. Have discussion with your clinical or education supervisor before you put something into practice, before you want to change your protocol. And you also must read a core emergency medicine textbook simultaneously. This is the FOAMed curve, and this is the FOAMed learning curve, and I think I fall in early adopters category, but most of the people whom I'm working with or I work with, they belong to the late majority category. And what this does is this creates a big disconnect between us, and because of that you can have arguments, you can have issues between you. So have formal discussions on FOAMed stuff before you put them into practice. Don't just start practicing just because you read it on some blog. This is important from the perspective of country where EM is still developing, and foam still needs to grow, and a lot of people are not really on board with this. Well, this takes us to the 10 points or tips and tricks to enjoy emergency medicine in India. Let's review them. So you need to start enjoying night shifts. Night shifts are not going anywhere. It is important, if you really want to take care of your patients, start enjoying night shifts. Talk to people, know your residents, achieve a work and life balance. Don't take it on your family. Read more. If you want to go into depth discussions with residents, your knowledge should be very strong. Work together, okay? Don't promote individuals, but promote the speciality. Hang out, find a friend, vent out. Don't be very hard on yourself. Always be willing to learn. Do not have a tunnel vision. Educate them, educate your residents. Communicate. You need to learn this. This is the most important, by far the most important skill for an emergency physician, to learn how to communicate. Find a mentor early in your career, and FOMED is the future. If you're not on FOMED, start doing it. Get involved, join Twitter, join Facebook, talk to people, collaborate with them. And that's all for me for now. I hope this talk would be helpful, especially for the EM induction training for the residents. Thank you, Nicholas, for putting this out, and thank you to all my mentors, colleagues, and friends. A special thanks to the faculty of teaching course 2014, Rob Rogers, Swami Salim, Victoria Brazil, Hanny Malima, Terry Mulligan, Michael Bond, George Willis, and Amal Matu. Thank you so much. This was really not possible without your support. I will talk to you next month, and bye-bye.